Low-cost workplace violence prevention tactics is our episode topic. My guest is Dave Corbin, a certified healthcare protection administrator, certified protection professional, and a healthcare violence and principal security consultant at Dynamic Security Strategies. Dave authored a white paper titled 10 Low to No Cost Ways to Prevent Violence. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Dave, thank you so much for joining us today.
Yeah, thanks for having me. Appreciate it.
Before we get into our episode topic, can you share a little bit about yourself with our listeners?
I have been in the healthcare security space for just over 25 years, both as a practitioner, director, and as a consultant, and fell into healthcare security a while back and fell in love with it, and I've been doing it ever since.
And how did you get into your field more specifically with a focus on healthcare security?
Early on in my career, I was doing retail loss prevention work, and I started to get bored of it. And I asked my professor at the time in college, I said, I'm looking for something a little different. And he connected me with somebody at a hospital who was hiring for an investigator. And I had no idea what an investigator did at a hospital. And anytime I told somebody I'm an investigator at a hospital, they said, what is there to investigate at a hospital? I said, you have no idea. Come into my world. And I had no idea. It was weird because I entered as an investigator, so I wasn't on the front lines all the time. So I wasn't really absorbing everything. And as I got more into my role, I realized that I was in not just a role, but in an organization that was there for the greater good. It was serving other people. It was helping people who were in need versus the retail world, which was trying to protect profits all the time and stop people from stealing, basically, most of the time. It was a much more rewarding environment and a better mission, which I identified with all the way. And I felt like if there's a way for me to support this important mission, to protect the people who are doing the work every day, that's really what spoke to me about the field. So I started as an investigator and then worked my way up into a few different roles on the operations side as a 3 to 11 shift lieutenant. And then I moved up into a special projects manager position before getting my first director role at a community hospital, director of security, and then really worked my way up to another larger role at another community hospital before landing at an acute care hospital as my last healthcare role prior to moving towards biotechnology and then moving into a consulting role. So that was my pathway, but it really wasn't, I really want to work in healthcare. It was like, this job looks interesting. And once I was in, I never left the field.
This episode is a continuation of a series that we've had focusing on the prevalence of workplace violence in the healthcare settings. As early as season 2, episode 6, we talked with Bill Schuler about addressing workplace violence. Later in that year, in episode 18, we talked with Becky Harris about addressing verbal aggression as a strategy to reduce workplace violence. And then in season 3, episode 5, Dr. Patty Howard talked about key leadership challenges and leadership strategies in addressing workplace violence. But today, we're here to talk about your paper titled 10 Low to No Cost Ways to Prevent Violence. What was the impetus behind writing this?
In my consulting across the country, I have found that a lot of my clients and even potential clients worry about, okay, when you're done with this risk assessment that you're doing for us, and whether that risk assessment is around general security measures or specifically focused on workplace violence, they're worried that I'm going to come up with all these recommendations that cost hundreds of thousands or whatever, millions of dollars that they're going to have to invest. And I always tell them that most of my risk assessments leave you with a list of recommendations, the majority of which are low or no cost. And when I say low or no cost, I don't mean that there's not a time investment needed, but in terms of capital outlay or having to maybe hire a new position or something like that, it requires time and effort. But some of the most impactful things that I've seen that you can do in the healthcare setting that can impact and have a larger impact on workplace violence have a low cost or no cost at all. You just mentioned leadership and the challenges around leadership with healthcare violence. And one of the things that I talk about in that white paper is engaging leadership as part of the workplace violence strategy. And that is such a huge part. And that does not cost money. Cost time. You're going to have to spend some time getting leadership on board with your ideas, with your program, with your initiatives. But ultimately, that time is going to pay off big time.
And one of the tactics that you mentioned in your paper is to encourage reporting. And a lot of health systems already have various different quality reporting databases that exist. Don't they already know that they need to report violence? Isn't that understood? The pendulum's really shifted in the last 10 years from no one wants to hear about it to encourage reporting. So isn't that situation already fixed?
I would say no. And despite the fact that workplace violence has become more, let's say, mainstream, that more people are acknowledging that it's an issue and that more hospitals and healthcare organizations are doing something about it, there is still a lack of consistent reporting in most organizations today. And when I look at the numbers that I see at various hospitals, or I see them publicized by the media, I'm like, that is not telling the full story here, because whatever that number is, I always think it should be probably at least doubled, whatever that number is that you're seeing. And in your organization, probably seeing that. And the reasons for a lack of reporting vary. But what I have seen and what I've seen in research as well is that, and this goes back to leadership, is that if you file a report for workplace violence and no one ever comes to follow up with you, and that happens a few times, you're just sending reports into a digital black hole somewhere and nobody ever comes to follow up. And then you see that all these reports aren't making any changes, right? Your manager isn't coming over to check on you. There's no security follow-up. Nobody's really coming to follow up, and then you're not seeing anything change. So eventually you start thinking, what is the point of this? Why should I report this? And that can also happen peer-to-peer, where people are like, don't bother filing a report. Nothing ever changes here. Just forget about it. We're too busy or whatever. The leadership, making sure that people are following up on reports every time, making sure that there's an actual outline process to follow up on reports of workplace violence, and using those reports, the data, the trends, to make changes when it's necessary to improve things. And even just following up on a report can go a long way to let somebody know that this isn't something that you're just filing a report to file a report. We're actually taking this seriously, and we're actually using this to move the needle. That's why it's important. In the high-risk units for violence, like the emergency department, like the ICU, like inpatient units, basically every inpatient unit out there, psychiatric units, and inpatient general med surge inpatient units, honestly, usually outpace behavioral health units for violence, unless you have some kind of forensic or very high-risk unit. I see those units often outpacing behavioral health areas because they have such a wide mix of people with all different issues happening. And sometimes they have behavioral health issues, and they also have a medical issue that needs to be treated on that unit. There's a lot of drivers for violence, but the higher risk the unit, the more contact that staff are having with violence, their tolerance starts to go up. And anybody who's ever worked in an emergency department can tell you that it takes a lot for them to report something.
Yeah. To that point, though, and you were talking about med surge units, is it that there really is violence that high on med-surg units, or does it look like it's higher than what the actuality is comparatively to the other units because the EDs aren't reporting it, the psych units aren't reporting it, the behavioral health units aren't reporting it, and so we have maybe a more accurate understanding of what the volume is in the med-surg units, and we know that the ED is likely above that. What are your thoughts on that?
I do feel like behavioral health staff are more likely to report, but in terms of inpatient units, I do feel like there's just so many different patients, different needs. There's oftentimes staffing issues. There's a variety of factors that play into it, but I do see those units they're busy. It's hard to put your finger on it because I feel like everywhere in every hospital, there's a lack of reporting. And I think that, to your point, yeah, the folks in the ED are definitely going to way underreport. There's also a higher volume of overall violence, right? So whatever percentage that's getting reported is still probably higher than everybody else. But when you get to the inpatient units, I do feel like they can also get overwhelmed. They don't want to do the report. They don't see anything changing. And there's just such a mix of so many patients with so many different issues. And that's where the guy who was spitting on staff in the ED is going to end up on that unit at some point, right?
Yeah.
Without the same level of security, without the same level of folks that know how to deal with somebody like that, because the ED folks are hardened, for better or for worse, and they know how to deal with people who are in crisis, and they know how to handle them. They have more immediate options at their disposal. And then you get to the inpatient unit and it's a different game. And they're trying to manage that same patient with less resources and less immediate access to whatever they need. So I think that there was a study recently where it was in an emergency department and they did this whole campaign around encouraging reporting where they got the managers involved and they actually made a QR code that the staff could scan and use their phones. They were able to scan it and put a report in without having to log into the whole reporting system. Somehow they layered it on top of it. So I don't know the details. It's HIPAA compliant, I'm sure. But they did it in some way where they didn't have to log in. They could do it from the handheld device and they could put the basic information in and then fill the rest in later. I think the reporting went up, like in 6 months, it went up by 1,000% or something crazy like that. It just went through the roof because they made it easier. All the managers and supervisors were in on it and encouraging them to do it. They did education for the staff around why it's important. That's just one emergency department, and that's just a 6-month study. And I'm sure after a while it would probably calm down, but it gives you an idea of the lack of reporting. People aren't reporting. They're not getting the help they need. You're not identifying trends. You're not identifying the causes of violence in that particular area. It really is a disservice to any organization not to have really a sharper focus on encouraging reporting. Not just saying you should report this, but to make it worth their while by having a follow-up, by using the data to improve things, by communicating people the value of their reports. It's a whole campaign, and it's like, among all the other things, you have to focus on at healthcare. Yeah. So there's another thing, but it does pay dividends at the end because your staff feel supported. You're identifying issues. You're improving your program based on real data and not just guessing what you think might work or what's working for the hospital down the street or whatever, which I see a lot of people doing is they're just grasping at straws, trying to figure out what's going to work and then trying different things without necessarily having a full picture of what's happening.
You've talked about a couple of important things here. One, leader support of the reporting, then also the ease of the reporting. At what point in time are we or should we be externally reporting something to whether that be law enforcement or the Department of Health or OSHA or something along those lines?
Yeah. So I think that the OSHA piece, I feel like the OSHA piece and Department of Health, that's typically at the organizational level. I think it's certainly an avenue for folks who feel like they've exhausted every other way to bring attention to workplace violence. I see a lot of labor action aimed at reducing workplace violence. I see that as a common theme now when there's a contract on the line that workplace violence is one of the central issues that they want dealt with in addition to staffing. Those are the top two that I see oftentimes. Obviously, there's pay and benefits and other things like that, but The workplace violence has risen to the top of that. And I see that fairly consistently across the country as being a main point. In terms of reporting out to law enforcement, I think it's important that every healthcare organization not only encourages staff when they feel like they need to report to law enforcement, but also supports them in the process. Meaning, if sometimes people don't think to file a police report in the moment, they're just like, somebody tells them you should call the police. I don't want to call them right now. They get home, they talk to their family, their loved ones. They come the next day. I want to file a complaint application for this person so that I want to get them into the criminal justice process here. And if you don't know how to do that, and if you don't have internal expertise, that can be hard. Yeah, you can call the police and they can come out and take a report. Or they might want to go and apply for a criminal complaint if they have a police department within their hospital. Some hospitals have their own police department, or if they have somebody knowledgeable that can help them. But eventually they're going to have to, whatever route they take, police report, filing an application for criminal complaint, whatever they're doing, they're going to have to show up at court at some point. And that should be, in my mind, that there should be a security, or if they have internal police, somebody escorting them, meeting them there at the courthouse and helping them through the process. Because if you've never done that before, it can be very intimidating. And I think also informing people ahead of time, this is what you should expect after you file a police report. And the police should explain this. They don't always explain it. But hey, I know you want to file a police report. This is what's going to happen. Police officer is going to ask for that information. At some point, you are going to have to show up in court. When you show up in court, the person that you're accusing is going to be there if they show up. And see them again. I just want to let you know that. And I also want to let you know that it's not like watching Law and Order show where the person gets arrested and jailed all in the same hour. This can drag on for months, years, and the outcome that you get ultimately might not be what you expected. They might not get any punishment, right? You might end up at a trial and they still don't get convicted, right? So there's so many different avenues. And I think setting expectations for folks before they get in too deep so that they understand what they're getting into is important. And I think for some folks, going through that process is closure for them, right? It's, even if it doesn't result in that person serving jail time, for them, it feels like closure because they did everything they could to hold that person accountable. And I've seen people just feel good about that. But other folks have this false expectation of what they think is going to happen, and that they're just going to file a police report and they're never going to have to do anything again. And that person's going to get arrested and charged or whatever. It doesn't always work out that way. So I think having someone in the organization, usually security, police, to help them through that process, support them, help keep them safe. And sometimes there is a safety planning element of it that has to be done as well, because it could be somebody who's threatening a staff member, right? That's saying, I'll find you, I'm going to kill you, I'm going to kill you and your family, whatever. I feel like for some people, the threats are worse than actual violence. If somebody punches you in the face, at least you know what you're getting, you know what you got. I find threats to be more concerning for many people, because it's like, yeah, I see you get your full name on your ID. I'm going to find you. I'm going to look you up and show up when you least expect it. And 99.9% of those are just people talking. But for the victim, they never know. There's no way to be certain. You can do a threat assessment, a violence risk assessment. You can do all that stuff. But ultimately, it's hard to predict what people will do. So having a safety plan for folks is important, especially when they've been threatened or if they feel unsafe. And hey, when you come into work, call us in advance. We'll give you an escort from your car to the hospital, or we'll help you on the way out. And here's some things you can do at home. And here's some other tips. Just that overall wraparound support for staff. And obviously having an element of that also involves your employee assistance program or some version of that that's in place to support the emotional side of it and the psychological sort of impact of things. But really, it's more than just filing that police report. It's the support that happens afterwards. It's the safety planning. It's all those things. There are some organizations out there, sadly, still that discourage people from filing police reports, that discourage people from pursuing criminal charges against somebody. It still happens. that's where you're starting from square one. If you have an organization actively discouraging people from filing police reports and trying to file charges against patients, that's a downhill, very quick downhill slope, because now they're not going to be reporting anything. They're not going to feel safe. They're going to feel like their job is in jeopardy, that they'll be retaliated against if they file a police report. So there's a right way to do it and a very wrong way to do it. And I think that not every hospital has all the resources to support people in the way that I'm saying, but to the extent possible, I think it's very important that healthcare organizations support their staff throughout the process, from the call to the police through the end of the criminal justice process. I think it's right.
Yeah, you're making me think about an organization that I was at, my gosh, maybe 3-4 years ago. Probably on the positive side, one of the most robust post-incident support wraparound service programs I had ever seen. In that scenario, at that organization, that individual, the victim in this case, right, the employee that was assaulted or battered, their point of contact was the occupational health nurse within the system. You mentioned earlier security department, and I guess there's a bunch of different ways that you can do this, but do you have a specific recommendation around post-incident support, who that primary point of contact should be? And then at the incident review level, who all should be involved in that aside from security and maybe that person's direct supervisor?
It's important, first of all, to have the staff members' immediate manager be part of that, because I was actually talking to a colleague of mine that is in a workplace violence. She's a clinician in a workplace violence prevention and mitigation kind of role. And she said, when she follows up with staff after a workplace violence incident, they'll say, I know you care about me, but I haven't heard anything from my manager.
Okay.
And it's like, how can I be supported in my workspace on my unit if my manager doesn't even, do they even know? Do they care? Like, why aren't they part of this? So I think having the direct manager for the unit, for the area, wherever they're working, be a part of the follow-up is important, because that is the tie locally to what's happening. That's the person who knows the victim the most likely, right? At that level, I would say, and can monitor the situation and let somebody know if something needs to be tweaked about the plan that's happening or support. So first of all, the manager should be involved. And security should be involved from the standpoint of safety planning, both on the unit, around the hospital, just making sure that person feels supported, coming out with a personal safety plan if needed, any investigative support around the incident, and follow up if they're going to pursue any criminal justice process. And then, like, what I have seen is someone from HR be part of that follow-up process as well, from the standpoint of employee support and employee relations kind of standpoint. It's OC Health nurse, I think, is in that same orbit, right? Because they're bridging the sort of like the bridge between HR and the clinical side kind of thing, right? They're kind of treading that line. I think in many organizations that I've seen, though, that OC Health service is so low staffed. There's not a whole lot of people working in there, right? And they don't have the 24-hour presence. And I think the 24-hour presence is, I've never seen a 24-hour presence from an OC Health nurse, and maybe in the larger organizations they have them, but there's also not a 24-hour HR presence, right? So I think that it doesn't mean that HR person has to respond to the scene and follow up, or the health person doesn't have to, but within a reasonable period of time, there needs to be a follow-up. And I think in my last organization I was in, I think it was like a 24-hour policy. Like within 24 hours, there needs to be a follow-up by security, person's manager, and HR. And then sometimes it was like the staff member was like, okay, this is great. Thank you all for following up. I just wanted to file a report in case my back hurts later this week. And they're like, thanks, but no thanks. And other times people are super grateful and want to engage the services. And between HR and security, they were able to connect them to whatever they need. And it's always both sides of the coin. They're both encouraging, them to take advantage of the EAP if they want. And I know that's not something that everybody wants to take advantage of. And I know there's some stigma around seeking EAP help for some folks, but
it's such an underused resource, though, for employees. I don't know why more don't take advantage of it. Probably
it is. I think there is. And what I've done in the past, if there is an incident that impacts more than one staff member. Let's say it was a seriously violent incident, multiple people got hurt, or somebody witnessed something terrible. There's all kinds of scenarios you can think about in healthcare setting. But to invite somebody from EAP to sit down with the staff and just have a light discussion. Hey, why don't the four of you go? I grabbed the conference room, got somebody from EAP in there. Just go in, and if you want to sit there in silence, go for it. But I'm not forcing you to say anything, but just go in and you guys can process. And when you get more people in there, some people feel better about sharing. But I'm going to bring the EAP to you.
Yeah.
You do it what you want. Have a debriefing, talk about it generally, whatever. But sometimes that helps open the door, even if the person's not saying anything there. Maybe I'll make an appointment or something. So it's just a way to help destigmatize it because, we're all here together. I'm not seeking help. It's all of us here together, and it's a safe space. I've done that when there's a larger group of people because I don't want to ever put somebody in a room with the AP. Hey, you have to go meet with them now. But bringing them into a larger group and calling it a debrief or whatever you want gives people a little different view on it. To answer your question, I think every organization is different, but security should also always be part of the follow-up. The manager should always be part of the follow-up and sewn into any plans, follow-up plans. And HR, I like the idea of an health person, especially if the person's been injured, right? Not everybody who's experienced violence has been injured, especially if it's a threat or if it's a near miss or whatever it was. But I think those key elements are the right folks. And I think that if there is a serious incident of violence where somebody's seriously injured, then there's somebody from senior leadership needs to be plugged in to that as well. I'm not saying the CEO needs to go down and say, are you okay? But maybe that's the CNO, right? Elevating that to the right level for the level of severity to let them know, hey, this is at my level now, and I want to let you know that we're supporting you and here's what we're doing kind of thing.
We've talked a lot about almost the afterthought before we talk about prevention, which is the post-incident thing, but learning from those experiences can help you better shift to the prevention side.
Absolutely.
When we talk about on the prevention side, you say in your white paper that if you can point at it, it's probably not helping to prevent violence. And
right.
What exactly do you mean by that?
I often see, especially after a seriously violent incident, you see the media release that, we're putting in more cameras, we're adding panic buttons, we're doing this and that. It's okay. The first question I always have is, what are you doing for training? What are you doing for raising awareness among staff? How are you supporting them after they file an incident report? Have you conducted a security risk assessment, a workplace violence assessment? Because things you can point at do not prevent violence. I have seen absolutely no evidence that security cameras prevent violence. No evidence that body-worn cameras prevent violence. And I know that's becoming a trend where nurses are being given body-worn cameras to walk around with. They're touting them as a way to prevent violence. Yes, they will absolutely record violence and help with prosecuting that patient later on or reviewing it. It can help protect nurses against false accusations. It can record other important evidence, but it's not going to prevent violence because most of the people who are committing violence aren't doing the math around, you have a camera and therefore if I hit you, I'm going to be on video and that might result in my prosecution. They're not thinking of that. They're not even thinking straight half the time, or they have criminal intent and they want to hurt you regardless. So most folks aren't doing the calculus around risk versus reward who are acting out. They're in crisis. They're in a bad way. They're angry for whatever reason. They're acting on their emotions or for any variety of reasons. And people aren't doing the math around this. Panic alarms, duress alarms, I think are great, especially the ones that are body worn that people have with them all the time and that they don't have to run to a nurse's station to get. But they can only prevent violence to the extent that they're used properly. And I find that a lot of staff, if they're not trained properly, feel like there's a high bar to activate the panic button. Like I remember earlier on in my career walking around and saying, I have to test your panic button. Do you want to press it to see what it's like? I don't know. Is it okay? I'm like, I'm from security. Nobody's coming. You're not going to get anybody upset. And they still wouldn't press. They were afraid to press it with me there telling them to press it.
Oh.
So some people have this high bar that is set, right? Not everybody, but some people are like, that's only for real serious emergencies. And when people get these body worn panic alarms. They think the same thing. I have to be basically being strangled to get to press this. When it should be the opposite. It should be if you see something escalating, somebody's getting that, you go in the patient's room and they throw a cup of water at you through the doorway. That's time to press the panic button, not after you go in and try to talk them down and they're getting more angry. Or if somebody says, don't come in my room or I'll kill you. It's like, all right, that's time to press it, not after you had your supervisor come by to talk to them, and use them more proactively, right? When you feel like you're in danger. To that extent, I feel like duress alarms, panic alarms don't necessarily prevent violence. They can get you help faster, but they're not necessarily going to, again, if you show that to the patient, I'm going to press this button and then security's going to come. So they're not here right now. So I don't think those things prevent violence. And also, weapons detection is something that often gets put in as a knee-jerk reaction after something has happened. And I think that there is something to be said about weapons detection. Keeping guns and knives out of hospitals is important, right? Because most people who are carrying, like in my experience with some of my clients who have weapons detection, most people who are coming in have no intention of using the weapon that they're carrying. They're carrying knives, pepper spray, firearms, especially in high crime areas. People are carrying for protection. They didn't come in there with the intention to shoot somebody or stab somebody. But healthcare is a very high stress environment. And if you get angry at the doctor who was caring for your mom who just passed away, and you're getting in a heated discussion, you have access to a firearm or a knife or something like that, is not a good situation. So I think that being able to screen for weapons at the entrance is a good idea. But I think doing it with the idea that it's going to prevent violence is misguided, because it will prevent the risk of that weapon and being introduced into the environment, being used. But most of the violence happening in healthcare is happening at a bedside. It's happening when somebody's grabbing a nurse, scratching a doctor, spitting in someone's face. It's not happening by the random visitor that comes in with a firearm, a knife, pepper spray. Most incidents do not involve weapons in healthcare. The ones that do are usually newsworthy and devastating, as we saw in Pennsylvania recently. The idea is if it's technology, it plays a role in the overall layers of security that you need in place in a healthcare environment. But if you install technology with the idea that it's going to prevent violence, you're giving people a false sense of security in my mind, because you're saying that this device is here for this purpose when it's not. It's there to record evidence. If it's a camera, it's there to give security more eyes and more areas to monitor, right? Same thing with body-worn cameras. Panic alarms are great to alert security and your colleagues when you need help, and that's great. You can shorten the reaction time to get to you. Most of the things that prevent violence are not technology. They are training. They are getting support from your C-suite for your programs, from training your managers and supervisors how to spot the signs of violence and to identify issues that could lead to violence. It's about having the right policies and procedures in place, doing regular security risk assessments and violence risk assessments in your hospital, getting ahead of things. Those are the things that will have a true impact on violence, and they don't cost a whole lot in most cases. They are, again, they require time investment, they require attention, but they do not. You don't need to, they're not going to be in your capital budget, let's put it that way.
Any closing thoughts as we wrap up this episode?
Any hospital healthcare organization who is looking to prevent or mitigate violence, look at the core things that they can do that will actually make a real impact. And that really comes, there's many layers, but starting with your C-suite and getting them involved, getting a champion from the C-suite to work on the workplace violence initiatives, because that person can overcome hurdles and get the right people involved and move the needle a lot faster than you can if you're in a director role or even a VP role. You need somebody who's in a C-suite role to move the needle and engage the right people. And I would also say create a position, at least a half-time position, for somebody to run your workplace violence program. And it should be at least at the manager level or above. And that person should have a focus on running that program. Don't layer it on top of somebody else who already has too many things to do. But put the right attention and focus on it, both from the C-suite and from the leadership perspective.
Low-cost workplace violence prevention tactics has been our episode topic. Dave Corbin, thank you so much for your time.
Thank you. Appreciate it.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.